different advanced techniques for treatment of fibroids and endometriosis. All right, so LAAM procedure is one of the advanced procedures. So this is used for fibroid removal, and I will talk about it in detail. Dual port hysterectomy, meaning removal of the uterus. We use this procedure to treat adenomyosis, which is endometriosis of the uterus, as well as fibroids. So this is definitive treatment, meaning removal of the uterus completely. Endometriosis excision is another minimally invasive procedure specifically designed for endometriosis removal.
Dr. D, just
Yeah.
a minute. If you we're not seeing your PowerPoints advanced. Have you advanced to the second page?
Yeah, I have. Oh, that's weird. Okay. Let's see. Let me stop sharing and then maybe I start sharing again. Share. Can you see it?
Okay, now we're good to go.
Okay, sounds good. All right, so yeah, so LAAM procedure, again, fibroid removal surgery, dual port hysterectomy, which is removal of the uterus, and then endometriosis excision for endometriosis. So the LAAM procedure stands for laparoscopically assisted abdominal myomectomy, and it's a minimally invasive technique. It's a hybrid approach, meaning that we're using both laparoscopy and laparotomy to remove fibroids. You have two incisions here in the picture. You have a 5 to 6 millimeter incision at the belly button, and then about 3 centimeters, so 1.5 to 2 inch incision in the bikini line. So this procedure uses 2 small incisions to remove the fibroids. The advantages is that there's no hospital stay, right? So it's completely outpatient. And the recovery is about 2 weeks. Compare that to open myomectomy, which is the most sort of common way the fibroids are removed, even at present. And an open myomectomy requires a hospital stay, usually of 3 days. And of course, it has a 6 to 8 week recovery. It's the best option for fibroid treatment because, one, it removes fibroids completely compared to some other approaches that we'll talk today. Immediate symptom improvement. So if you have bulk symptoms like frequent urination or lower back pain or constipation or abnormal bleeding, typically removing the fibroids will immediately relieve those symptoms. It removes large and multiple fibroids. So this procedure is not limited to only, let's say, having medium to small size fibroids or only having fibroids in certain location of the uterus. You can remove one big one, or you can remove, 10 small ones. They can be inside the uterus, outside the uterus. So this procedure is very versatile, and it's comparable to an open procedure, but again, with advantages, having shorter recovery and no hospital stay. So these are different types of myomectomy. So myomectomy, the word myomectomy means removal of fibroids, but because myoma is fibroid and ectomy is removal. So this is the LAAM procedure, giving you the incision. So this is the small incision at the belly button, and then this is the incision at the bikini line. And this is a picture right after the patient had the surgery done. The blue drapes are still, so this is still in the operating room. This is a picture of an open incision. So with an open myomectomy, it could be either like a C-section incision, or it could be a large up and down incision, depending on what how big the fibroids were and how the surgeon wanted to do it. A robotic myomectomy is another minimally invasive approach. However, it requires multiple incisions. Also, the way the incisions are positioned, due to the robot arms, they have to be in the middle of the abdomen. So they kind of go in a semicircle. So this is the belly button. So the head would be up here, and the genital areas here. So they're in the middle of the abdomen going into the semicircles. And here's the ports for the robot. All right, so the LAAM is more cosmetically placed incisions. So again, comparing the LAAM procedure to robotic, laparoscopic, or open, the LAAM procedure takes less time. So robotic procedures typically are notorious for taking longer time. It takes longer to set up the robot, to what's called dock the robot, to attach the robot arms to the ports and to the instruments. So all of that takes time while the patient is under anesthesia. And also just the fibroid removal is slower. It takes more time using the robot. The LAAM procedure is much faster, and it's almost as fast. It's actually faster, but the open surgery is basically going to be as fast as the LAAM procedure, maybe a little bit longer. Hospital stay, like I said, no stay, right? Versus open surgery, 3 days. Recovery time, that's another big difference. With the LAAM procedure, about 2 weeks. With open surgery, 6 to 8 weeks. Pain postoperatively, there's going to be pain, right? Because it's surgery. So even though the incisions are small, there was stuff being done inside. The fibroids were removed and the uterus was stitched. So, and that's the same thing as done with robotic or open or laparoscopic. It doesn't matter the external incision, right? The same thing is being done on the uterus. So if you had 30 fibroids removed, even if the abdominal incisions are small, you're going to have pain. There's more pain with open incision because that incision is also very large in addition to whatever was done to the uterus itself. This is a paper that we published in 2018 on the LAAM procedure, comparing it to other procedures and kind of the outcomes. This was 1,300 patients that underwent surgery at Holy Cross Hospital in Silver Spring. So this study was about 10 years ago. And again, we found advantages of the LAAM procedure. So there were more fibroids removed using the LAAM approach than compared to robotic and standard. Why? Because with the LAAM procedure, we're actually able to feel the uterus and look for smaller fibroids that are deeper in the uterus. Those smaller fibroids can be easily missed with robotic surgery because with robotic or standard laparoscopic approach, there's really no way to feel the uterus by hand. It's only visual. So visually, if we see a fibroid that's sort of protruding out of the uterus, we know that there's a fibroid there. But if the fibroid is small and it's not protruding, it can be easily missed. Lower complications, so the bar that's yellow, that's the LAAM procedure. The highest complication was in the abdominal for post-op, and for intra-op complications, the highest complication was for the robotic surgery. The reason for the post-op complications, and what are they? So post-op complications are something like infection of the incision or pelvic infection, or needing a blood transfusion post-surgery. So things like that, or something requiring prolonged hospitalization, for example, pneumonia or ileus, which is when your bowels are sort of don't regain their function immediately after the surgery. So all those things are more common with open surgery. Intra-op complications, why was robotic higher? That may be due to the duration of the surgery, again, bleeding during the surgery, and it being more difficult to control the bleeding robotically. Shortest operative time for the LAAM procedure, and again, as I mentioned, with robotic surgery, that's pretty common to take much longer. So overall, again, length of the procedure, the LAAM beats out robotic surgery, and then the max of fibroids removed in that specific study was 103 fibroids removed on one patient during the LAAM procedure versus the highest for robotic was only 13. So again, you're going to be missing a lot of the smaller fibroids because robotic and the standard laparoscopic surgery really is designed to remove those external fibroids. So advantages, again, kind of going over the same thing over and over again. Open incision, right? You have a big incision and a long recovery. So really that's the bottom line. Open incision is the most common procedure that's done for fibroids because that's what most OBGYNs do. And when you have multiple fibroids, if the surgeon doesn't do the LAAM procedure, they're going to automatically offer you open surgery. With robotic, typically, there's a limit on the size of fibroids and the number of fibroids, right? So if you have 2 to 3 fibroids, maybe the surgeon will say, okay, let's do this robotically. But again, understanding that smaller fibroids could be missed. And remember, even on ultrasound, you you're likely not going to pick up all the fibroids. So ultrasounds or MRIs just give us a general idea about the uterus, the state of the uterus, but I don't rely on those imaging studies to tell me exactly the number of fibroids. That really won't be clear until the surgery. So that's the advantage of the LAAM, right? So it uses kind of advantages of both techniques, right? So you eliminate the limitation of size and number and location of fibroids, but you still keep the incision small to shorten the recovery. This is just a portion of the LAAM procedure showing how the fiber is actually extracted from the body, right? Because that's a very common question. The question is, okay, I have big fibroids and you're telling me the incision is going to be like 1.5 to 2 inches. So how are you going to get the big fibroid out? So this is how it comes out. So it's not cut. We don't use a morcellator. So power morcellator is a device that's used during laparoscopic surgery to grind up the fibroid to be able to remove it through a small port incision. So what we do, we open up this incision to what's called a mini laparotomy. So it's a very small incision, and then bring the fibroid up to the level of the skin. So right up to the incision, it's not being cut inside, and then it's being cut right there at the incision site. And then you just sort of remove it in this long strip while still holding on to the fibroid. So the small pieces are not flying off everywhere. This is very controlled, works very well, and it's very efficient. So this is an example of how many fibroids can be removed with the LAAM procedure. So this is 2 patients that happened to be done on the same day, but so this patient had 1 big fibroid and then 5 smaller fibroids, and this is the big pieces that the big one was removed in, and then the small fibroids came out intact. And this is another example. So this is multiple fibroids that were removed from 1 patient. So another thing is that when you go to even a minimally invasive surgeon, one question you should ask is, what is my risk of having to have open incision? What is the risk that I go into surgery thinking I'm having, robotic surgery or laparoscopic surgery and end up with a big open cut? So that was one of the things we looked at as well in our study. So it means conversion to open. So with the LAAM procedure, there's already a mini open. So it's about a 2-inch incision. So really, there's no need to converting to open because there's already a small open incision. With robotic or standard laparoscopic, all the incisions are just little ports. So really, if the surgeon cannot remove the fibroid using the robotic or standard technique, they have to convert to an open incision, or let's say they have excessive bleeding and can't control the bleeding robotically. So the blue box is the conversion to open with the LAAM procedure. So it's extremely rare. The grams here is the size of the uterus. So the uterus is measured in grams rather than pounds, but for example, 700 grams is about 1.5 pounds. So essentially, the bigger the fibroid, the higher the risk for open surgery. Standard laparoscopic myomectomy had the highest risk of open surgery. So essentially anything that was large, they converted to open very frequently. Robotic right behind it. All right, so that's another example of really disadvantage of robotic and standard laparoscopic surgery for fibroid removal because it has a much higher rate of converting to an open procedure. Now, shifting gears to uterine fibroid embolization. So let's say you said, I don't want to have any surgery. I don't want to have minimally invasive, open, just having surgery is not something I want to do. Let me look at other options. So a very common option is uterine fibroid embolization. So what that means is small particles are injected into the blood supply to the fibroid to cut off the blood flow, all right? Because fibroids are tumors, and every tumor relies on blood supply to grow. the fibroids are also estrogen dependent, so they need also hormones. They need blood flow and hormones. So if you cut off one, then the fibroid can't grow. So the uterine fibroid embolization targets blood supply. The disadvantage is it's not recommended for patients who are trying to preserve fertility. So if you're, I don't know, 25 years old and you have fibroids, you really should not do uterine fibroid embolization because it's going to impact your ovarian function. So meaning that the hormone production can be affected and you may be less fertile. And it also doesn't remove fibroids. So if there's a fibroid that's impacting your ability to get pregnant, doing embolization on that fibroid is not going to change anything, right? Embolization typically does not improve bulk symptoms. So if your fibroids are so large that you're having frequent urination, lower back pain, I don't know, constipation, pelvic pressure, your abdomen is protruding. So all those things should let you know that embolization is not the right option. Because if you embolize the fibroids, okay, they may not get any bigger, but they're not going to shrink to such extent that you'll feel a difference in those bulk symptoms. And that's why because it doesn't work well for large fibroids. So if you have small fibroids, fine. You know, let's say you don't want fertility, you have small fibroids, your main issue is really bleeding. There's a few, you know, again, small, medium-sized fibroids near the uterine lining, which is like this fibroid, this is the lining of the uterus. Embolization might be the right choice for you, but if you're trying to preserve fertility or if you have bulk symptoms, it's not the right choice. This is just a kind of depiction of UFE versus LAAM. So when you, again, so here's the uterus with fibroids. These yellow things are fibroids. And if you have a UFE, you know, let's say you embolize this fibroid, it's still there, okay? The other fibroids are still there as well. So this fibroid degenerates, so it kind of becomes, dies, okay, but it's still there. With the LAAM procedure, you took out all the fibroids, they're all gone. So essentially with embolization, the point here is that nothing has changed. You have this fibroid pressing on the bladder, that's still there. You have this fibroid pressing on the spine, that's still there. And then you have this dead fibroid pressing up against the abdominal wall and making you feel more pressure. Versus with LAAM, or really any myomectomy, once the fibroids are removed, the uterus is back to almost normal or normal size. All right, so any questions so far before we jump into the uterine removal? I can't tell, how do I get?
I don't see any questions in the Q&A, but we'll, this is your opportunity to go ahead and just jot down or drop your questions in the comment or Q&A. We would have a couple of other pauses, so if you don't have anything right now, we'll have another time that would be allocated again. We have one question, Dr. D. Do you see it?
Let's see, I saw it and then it went away. Where did I see it?
Can you do endo excision with LAAM?
Yes, yeah. Yeah, so and we'll mention it later, but yes, also one of the advantage of doing the LAAM procedure is that during the procedure you can see endometriosis, scar tissue, and that all it gets addressed at the same time. Yeah. And as far as like follow-up after surgery, so typically we tell patients to wait 6 months before trying to get pregnant, unless it was, if there were smaller fibroids or on the outside, maybe it could be less than 6 months, like 3 months. But typically with extensive fibroid removal surgery, 6 months is the standard. And then after that, what we do is we check the uterine cavity and the fallopian tubes for scar tissue, because those are the areas typically are of concern, because if there's scar tissue from the surgery in the fallopian tubes or in the uterine cavity, that can lead to infertility, right? So we want to check that before kind of giving the patient the green light to start trying to conceive. And of course, there's going to be variations. If the patient is older, we may, recommend egg retrieval and kind of starting the process of IVF so not to waste time. So during 6 months, that process can already begin.
Can you repeat, LAAM, if fibroid, we have a couple of more questions. Can you repeat LAAM if fibroids reoccur?
Yes, you can. I mean, it's never ideal to have more than one myomectomy, but the reality is that fibroids come back, right? So we have patients who've had prior, open myomectomy. We see patients who've had LAAM procedure with us and they're coming back for another LAAM procedure. But you have to remember that every time you have surgery on the uterus, that uterus becomes weaker and weaker. And the risk for scarring, risk for poor healing goes up. So that's just inherent to any, procedure. So the more things you do on the uterus, the weaker it becomes. Think of like a pair of socks that you have a hole in the heel. I'm sure you guys don't have to do that, but back in the day, I grew up in Russia, so we didn't buy new socks, we just repair them. So you repair the hole, and then, a new hole will form much faster, right? Because it's already weakened. So think of the uterus the same way. The more you repair it, it's just the integrity is not there. So it's always going to be weaker with each time. So again, it's not ideal, but sometimes, what can we do? The fibroids are back. Patient still wants to maintain fertility. And again, it's important to kind of understand the risks that are involved with that.
If we can do one more follow-up and then we'll move on.
Sure.
What are the risks if you get pregnant before the 6 months?
Uterine rupture. So when the fibroids are removed, the uterus is stitched together, right? And it's being held by suture. And as the uterine tissue heals together, the suture dissolves, right? So if you, let's say, get pregnant a month after the surgery, when the uterus hasn't healed, it can rupture, it can fall apart, come apart completely.
All right. Thank you, Dr. D. We can move on.
Okay. All right. Now, we're shifting gears now to talk about a hysterectomy, which is removal of the uterus. Now, why would you do a hysterectomy? Many reasons, but primary fibroid treatment, so definitive fibroid treatment. So let's say you no longer desire fertility or just don't desire fertility and you don't want fibroids to come back. A hysterectomy is a great option. Hysterectomy does not mean a removal of everything. There are different types of hysterectomy, and I will go into that shortly. But what is dual port or LRH hysterectomy? It's a hysterectomy using 2 small ports. So here's the port at the belly button, and there's another port the same size in the bikini line. So with that approach, the uterus and the cervix is removed. The fallopian tubes are also removed, and that's standard with any hysterectomy. And we preserve the ovaries, or the ovaries may be removed as well. All right, so 2 small incisions. We use advanced techniques inside while detaching the uterus that minimize complications like excessive bleeding or injury to surrounding structures. So it's sort of identifying vital structures and controlling the blood flow to the uterus to avoid complications. So comparing it to other techniques, so standard laparoscopic, so using or conventional, using multiple incisions, or robotic, again, using incisions kind of in a semicircle in the middle of the abdomen. There's also vaginal hysterectomy, which is what the entire procedure is done through the vaginal canal. There's also traditional open abdominal myomectomy. So the advantage is that there's fewer incisions, right? 2 incisions, which are small, less blood loss due to the techniques, shorter operative time also related to the techniques, fewer complications, shorter recovery, and no hospital stay. So again, this is completely outpatient, just like the LAAM procedure. This again, just comparing the incisions. So typically fewer incisions means less pain. Usually what we call them lateral incisions or incisions to the side are sometimes more painful. So we typically try to avoid them. Now, in some situations where it's very large fibroids or a lot of scar tissue from prior surgery, like let's say prior myomectomy or numerous C-sections, sometimes the 3rd incision is required on the side, but majority of the hysterectomies we do just using the two midline incisions, and that really it has less pain associated with it. Now, another study that we published in 2019 in a peer-reviewed journal, and this was examining this hysterectomy technique and comparing it to other techniques. Same hospital institution, Holy Cross Hospital, and this was 2,600 patients, and we looked at the outcomes. So again, number of incisions, our technique had fewer incisions, shorter operative time, and if you look here, the RALH is the robotic. So robotic hysterectomy had twice the speed of the laparoscopic retroperitoneal hysterectomy, which is our technique. So really the technique makes the surgery go much faster. And what it means for a patient is that less time under anesthesia, right? So less time under anesthesia means, less potential complications. Fewer complications during surgery and after surgery, and larger size uterus removed. So that's very important, right? So if I'm telling you that, oh, I'm doing everything laparoscopically, but then what really I'm doing is selecting only small uteruses with small fibroids, then that wouldn't really be fair, right? But we're comparing here across different techniques and all uterine sizes. So the largest size that was removed using our techniques was 9,000 grams. So 9 times 2 is 18. So that's about 18 plus pounds, definitely bigger than a baby. And then with open surgery, even with open surgery, where there's really no limitation on size, their largest size there was about 2,000 grams. So this technique is what allows us to do things to keep this surgery minimally invasive despite very large size. So this is this was the 9,000 gram uterus. Yeah. So this patient, obviously, so we talked about, Beza mentioned delay in care, right? Or delay in diagnosis. So there was no delay in diagnosis because at this point it was clear that there was, something going on, but delay in care. So why, you may ask, well, why did this patient wait so long? Many reasons, but one is being afraid to have surgery, right? So it sort of starts out like this. First, you have fibroids, you get diagnosed, your OBGYN says, you can just watch and wait. So then you watch and wait, and then they get bigger, and then you say, okay, what do I do now? And then they say, oh, you have to have open surgery. So we jumped from not having to do anything at all to having to have open surgery. Like what happened in the middle? What happened to the minimally invasive surgery, right? So the longer you wait, the fewer people out there, surgeons out there, are going to be willing to do minimally invasive surgery. So as you can imagine, this is the belly button, by the way. As you can imagine, this patient could not find anyone to do it minimally invasively. And then she ended up finding us. So, and this is the uterus, 2 very large basins. So these are like this big. So, and she did fine, but I definitely don't encourage anybody to wait this long though, because this is, that's a pretty complicated surgery. Now, to go back just in terms of what is hysterectomy and what is removed, there are various types of hysterectomy. So the hysterectomy where we're removing the entire uterus, including the cervix, it's called total hysterectomy, and then we also include the tubes. The ovaries would stay, and that's for hormone production. So if you're, in your 30s and 40s or 20s and premenopausal, you probably will want to keep the ovaries unless there's a extensive family history of ovarian cancer or some concern that the ovaries are not healthy. It can be just the body of the uterus or the fallopian tubes. So this is actually the most common hysterectomy that we tend to do, is keeping the cervix to preserve the vaginal length, to preserve the pelvic floor support, as long as the patient doesn't have any issues with pap smears, or getting pap smears. And then the full hysterectomy, meaning, the uterus, cervix, tubes, and ovaries. Sometimes we do that for reasons for cancer or let's say somebody who's postmenopausal, or let's say somebody who has extensive endometriosis. So this is kind of a word hysterectomy, means really, again, technically removing just the uterus, but in layman's term, we could be talking about any one of these three. All right, so back to the embolization as the option, as the definitive option. So let's say you're considering UFE versus hysterectomy, and obviously the fertility is not a concern, so we don't mention that. But now again, back to the bulk symptoms, right? So if you're having increased frequent urination, constipation, lower back pain, distension, pelvic pressure, so like the picture of the patient with a large uterus, obviously embolization would be a complete waste of time because it would look exactly the same after the embolization. So it's not good for big fibroids. All right, so any questions so far on the hysterectomy before we move to the endometriosis?
I don't see any questions on hysterectomy, but again, you can jot. I see.
Yeah, let me just see here.
Do you see that question that just came in from Ava?
Yes. Yeah, you can't reconstruct the cervix. So typically we recommend keeping the cervix, and it depends. So the issue with removing the cervix is that when you take out the cervix, there is some shortening of the vagina, right? So even though we don't take out any vaginal tissue when we remove the cervix, but when you take out something and then you close the top, you're going to be it's just going to look shorter, okay? It's going to be shorter without removing any extra tissue. So that's one. So the shortening of the vaginal canal. Next thing, to the pelvic floor support, you can't really reconstruct it. If you're removing the cervix, that's the sort of, those are the disadvantages. Advantages that you don't have to do a single pap smear for the rest of your life. If you've had normal pap smears prior to the surgery, then by taking out the uterus with the cervix, you're done with pap smears. So that's another positive. You would need to abstain from sex for about 2 months because the top of the vagina has to heal. If you keep the cervix, you don't have to worry about it. You can resume intercourse, let's say, within 7 to 10 days. But you do have to get pap smears, every 3 to 5 years. So it's pros and cons. The incisions, yes. So if you want 2 5-millimeter incisions, you got to get rid of the cervix because that's the only way to keep both incisions, the top and the bottom incision, 5 millimeters. Once the uterus is detached, we have to take it out somehow, right? So it either will come out through the vagina, but in that case, the cervix has to go also. If the cervix stays, then the uterus will come out through that bottom incision, which will be extended to about 1 inch to 1.5 inches. So, okay.
Let's see. I think this one has to do with, this may be premature question. Is the procedure covered by PPO insurance?
Yeah, the procedure is covered by insurance. It's just a matter of, if your provider participates with your insurance. But if there's an indication for a hysterectomy, then it's covered. Yeah.
And we typically, I just want to mention here that if you're curious about sort of consultation about your insurance and coverage, you can, like when you schedule a consultation with us, we'll be able to help you determine your insurance, sort of what's covered and what's not, right, Dr. D?
Yeah, we have a specific person assigned for that. So they look at your insurance benefits, and they also figure out whether a specific procedure requires prior authorization, meaning that we have to send the request and the records to your insurance company, and the insurance company has to, agree to the plan. And some procedures don't require prior authorizations, but most hysterectomies do. So we do that ahead of time. Yeah.
Okay, Thank you. We can go ahead.
Okay, sounds good. All right, so minimize that. Okay. All right, so lastly, excision of endometriosis. So endometriosis, right, the growth of abnormal cells or tissue in the pelvis could also extend to upper abdomen, could be in the abdominal wall. And so we use advanced techniques to excise endometriosis. So the whole point of endometriosis surgery is to completely remove it. So typically, if not all of the endometriosis is removed, then the symptoms can persist. Sometimes the reason why not all endometriosis can be removed is that it may be involving reproductive structures, and let's say the patient desires fertility, but sometimes it may not be removed because it's near rectum or near bladder or near ureter, and that's why you need a laparoscopic expert to successfully remove it without injuring those structures. So the more complete you excise or cut out endometriosis lesions, the lower the risk of recurrence. We, again, do not use a robot, again, using the 2 small incisions. And typically for an average endometriosis excision surgery, recovery is about 3 to 5 days, and it is, of course, outpatient. So this is example of excision versus ablation. So this is excision. The shiny surface is called peritoneum, and that's what usually where endometriosis grows. So here the peritoneum had been excised or cut out. So we just cut around like this and then just strip that shiny layer. This is another example just of a larger area that's been excised or removed. And then over time, this area heals. So it kind of the peritoneum grows back over it. This is ablation. So this is just burning that area. So it's usually used either by cautery, laser is sort of like old to, most people don't use laser anymore, but back in the day, we used laser as well. So it's not as effective as excision because you may not destroy the tissue completely. Also, you can't really burn. Here is okay. This is sidewall. This is like your muscle. But if you go to the bladder area or to the bowel, you can't burn there. So, for example, an OBGYN who mostly does ablation may not even do any, may leave the lesions near the bladder and the bowel because they can't burn there. All right. So excision gives you the ability to remove all endometriosis without injuring the underlying tissue. So endometriosis can be there even when you're not suspecting, right? So that's why with myomectomies, a lot of times we find endometriosis at least 50% of the time. So when we're doing a myomectomy, first thing we do is always look for endometriosis. And it's a common cause of infertility and pelvic pain. So this is a study that we published. So this was a chart review. So we looked at 350 patients, and we found that if you do a complete incision, and this is patients with stage 3 and 4 endometriosis. Okay, so this is the more moderate to severe. And what we wanted to do, what is the reoperation time over a 7-year period? And we found that with extensive excision, patients can actually go for a while before needing surgery because their reoperation rate for pelvic pain was only 3%. This is a study that looked at specifically finding endometriosis during LAAM surgery, and we found that at least 45% of patients who were undergoing fibroid removal surgery also had endometriosis. So that's why it's really important to look. When we looked at previous reports, they actually underreported endometriosis. So they said that during laparoscopic myomectomy, the coexistence was about 12 to 26%. Our findings is actually more. Why the discrepancy? Maybe the, how much the person is kind of looking for it, right? Because some lesions can be very subtle, and we really take the time to look for endometriosis because we know that it does impact fertility. So in conclusion, you have to really make sure you're choosing the right procedure for you. And of course, talking to the specialist and kind of working together and trying to figure it out together is very important, because everybody's situation is different. You know, it's not uncommon for a patient to come in kind of thinking about one thing, but then once we discuss and talk about it, we realize that that initial plan may not make sense, and it's going to be more beneficial for the patient in terms of safety, in terms of outcome, to have a different procedure. So again, it's very important, but at the end of the day, you really, you know, have to feel comfortable with what you are going to do, right? But make sure that delay in care is really not keeping you from getting the best treatment.
Great, thank you. Now we have plenty of time. We have about 15 minutes, and I know a lot of you are still with us. So this is your opportunity to ask any questions. Dr. D, this has been great. And I'm sharing a couple of links in the chat box. You see the question coming in, Dr.
Yeah.
D, you can just, I'm sharing a evaluation and consultation if you want to schedule a consultation, and I'm going to encourage you to please complete that evaluation form. It does help us improve our programs. So I'll go ahead and have you address the question that just came.
Yeah, so the question is, if you currently have fibroids, subserosal, intramural, pedunculated. So this is different locations of fibroids. So essentially, multiple fibroids, but no submucosal, so no fibroids inside the uterine cavity. They have enlarged. The uterus is approximately 19 centimeters. So when we measure a uterus on ultrasound, we measure it in centimeters kind of length, right? And that is equivalent to the weeks of pregnancy. So 19 centimeters is like being 19 weeks pregnant. So it's pretty large. So that means it extends to the belly button. So which procedure would I recommend? So it depends, right? So things to take into the consideration: the patient's age is very important, because, and then their desire for fertility, right? So let's say if I have somebody who is 49 years old and they don't want to get pregnant, they either already have kids or have no interest in having kids, then I'm going to say that the best procedure for them is going to be a partial hysterectomy, where we'll keep the cervix and just remove the body of the uterus with all the fibroids, and remove the fallopian tubes, but keep the ovaries. So this way, you know, we completely eliminate all that bulk, right? Because that uterus is now this big, and that's it. And we don't have to worry about fibroids coming back. We don't have to worry about any of that. If it's someone who is younger and they want fertility, then we have to talk about removing the fibroids only, right? But the disadvantage of that is that fibroids can grow back. The advantage is that by keeping the uterus, we're giving this patient the ability to conceive. So really, and then now, what about if I have someone, same example, 49, who wants to preserve fertility? Then a large portion of that discussion is going to be around, well, how do you get pregnant at the age of 49? So typically that involves a donor egg. So a lot of times we will involve the reproductive endocrinologist and the consultation with that specialist to really discuss what is involved in donor egg IVF, and whether, you know, and once the patient sort of understands that option, right, and they still feel that that's a viable option for them, then we do the fibroid removal surgery. So, all right. Okay, what to expect with the first menstrual ovulation cycle post-surgery with endometriosis? So it depends. Most of the time, I would say the first period is painful because things are still healing. But in some cases, if the surgery was a couple of weeks away from the period, by the time the period comes, it is supposed to be better than the periods prior to surgery. If the cysts are cleared, so if the endometriosis cysts are removed, how quickly can they grow back? So that's a good question. So if you look in the literature, it talks about the risk of recurrence is higher in younger patients, which makes sense because, if you're taking out an endometriosis cyst in someone who's 45 years old, then because endometriosis is hormone dependent, and because a 45-year-old is going to be producing fewer hormones than a 25-year-old, most likely the likelihood of having to do another surgery on someone who's 45 in the future is lower than in a 25-year-old. But some of that also depends on how the endometriosis was removed, or the endometriosis cyst, endometrioma. Because with endometriomas, so endometriomas are cysts that are inside the ovary, okay? And it requires, just like let's say a fibroid, it requires opening up the ovary and then peeling out that cyst. So you have to remove the entire cyst wall when you're removing the endometrioma. If a piece of the cyst wall stays inside, if it's not removed, then the endometrioma can grow back. So a lot of the recurrence, it growing back, is dependent on how the surgery was done. Occasionally, I see patients who have had the endometriomas drained, which is just not taking out the endometrioma at all. It's just going in and suctioning out the content of the cyst, which is like this thick, dark, kind of brown material. That's completely a total waste of surgery. Absolutely. Because if you just suction out that fluid, it'll just fill back up. So, and that's typically done with laparoscopy. So essentially that patient had a, wasted surgery. They had surgery for nothing. The cyst is back. So that reaccumulates within a couple of months. So that's another reason to go to a specialist who can effectively remove the endometrioma and decrease your risk of it coming back. All right, is your cycle overlapping with your LAAM surgery a problem? No. So yeah, that's a very common question. So like, do I have to be off my period when I have my surgery? No, that's not a problem, because that would be way too difficult to coordinate. We have a lot of patients that have abnormal bleeding, frequent bleeding with fibroids. So it's not a problem to have your surgery while you're bleeding, or to have your surgery right before you expect your period, or after, it doesn't matter.
Hey, keep your questions coming. I'm gonna also just mention now, like I mentioned at the beginning of the webinar, we have been doing this every month. So some of the specific conditions that Dr. D talked about, we've also allocated a whole entire hour just discussing endometriosis on its own, from how to diagnose, to symptoms, to treatment options. Same with fibroids, adenomyosis, pelvic pain. And we just recently did a webinar also on fibroids and connections to vitamin D. So if you're interested in going back into the archive and just watching some of those videos, they are available in our on our YouTube channel. There's an archive with a list of all of us, the expert webinars. All of them are available online. We also do this, like I said, every month. So we are going to repeat them sometimes if you want to come in live and ask questions, as well as just sort of have those up-to-date information on the conditions. And so I'm going to encourage you. I know a few of you actually are new to this program. So if you're not part of our mailing list, and you're interested in being part of our mailing list, please go ahead and notify me when I send a follow-up email, so that you get notifications about our upcoming webinars, and as well as we share patient stories as well. So,
all right, I'm just gonna keep talking just in case Beza is the only one who froze. A couple other questions.
Dr. D, can you hear me?
Yes, yeah.
I apologize. My internet just kicked me out of here. I don't know how much of what my spiel was people heard, but I was saying that if you have any questions or some of these conditions that we talked about, we actually do have an archive on our YouTube channel with all of the webinars that we've done so far. And if you're interested in just kind of joining in and just getting up-to-date information from Dr. D about the different conditions that we talk about. We do these every month, and I see a whole lot of you are new to this program. So if you are not part of our mailing list, please go ahead and reply to my email that I'm going to send in the follow-up, and we'll add you to our mailing list. I see that a couple of questions have come in the
Yeah, I answered the questions. The only thing is that I guess Fran had issues with getting into the webinar, and she wants to know where did she get the video.
No worries. Yeah, if you have, and we apologize. Typically, we don't have. We always pray for the internet gods to not have any technical difficulties. But if you did have technical difficulties on getting into the webinar, we do share the recording right after the webinar. So I'll send a recording in my follow-up, and you should be able to access that. And we'll also be repeating and doing this webinar again sometime soon, maybe sometime in the fall, right, Dr. D? And one thing that I also want to mention is that we are organizing, we're going to do a mini conference sometime soon. So be on the lookout for details about educational programs that come from us. There is a question, I don't know if you've answered about the cutoff for fertility assistance. What's the age cutoff for fertility assistance?
Oh, sorry, I must have missed that. Age cutoff for fertility assistance. Well, it's going to depend on the fertility practice. I think Shady Grove and most fertility practices in the area, I believe they use the age of 52 as a cutoff for a donor egg. But I don't quote me on that because those things change. There's not really like an official cutoff, but most practices will have, you know, so like if you are, let's say 75, you're probably not going to be able to get a donor egg IVF in this country. So you would have to travel overseas. Yeah, I believe 52 is the cutoff for most practices for a donor egg. For just general IVF with your own eggs, I mean, it's really just depends on your own desire to spend money. I think, you know, most legitimate practices will give you the chances, you know, they'll say, oh, you have less than 5% chance, right? So they may still offer you to do IVF with your own eggs, but understanding that the cost will be high and the yield will be low. So if you're sort of willing to accept those numbers, they may still be able to do it. So, but yeah, you just have to, depends on which practice you go to in terms of cutoffs. If I find a cyst that's cancerous, seems to be cancerous, it's tested, of course. Everything gets sent to pathology regardless of whether it appears cancerous or not. Majority of the time, you know, there is some suspicion. So in most cases, there is suspicion if there's cancer versus not cancer. And typically, you know, in 99% of the time, that suspicion is correct.
All right. Thank you for being such an engaging group of people. Thank you. And Dr. Danilyants, as always, I appreciate you taking the time to do these educational programs. As I've mentioned, we do these every month. And so if you're interested in kind of getting more information or learning more about us, I'll encourage you to not only visit our website, because we have so many great resources there, but also check out our socials. Dr. Danilyants does she addresses current issues or addresses some of the questions sometimes we get here in these webinars and on our socials as well. So if you're not following us on our social media, just go ahead, and I encourage you to do so. Otherwise, I'll just stay for another minute or so that you have access to that evaluation link. And I highly encourage you to complete that. Dr. D, I appreciate you. Thank you so much. I think you can log off if you like, and I'll just stay on. Thanks.
Great. Thank you so much, everybody. Thanks for your attention. Thank you.
Bye.
Bye. All right.
See, I will share the socials right now. Thank you. I'm sharing links in the, if you're interested in following us on social. If you have questions about insurance and the type of insurance that we accept, what I encourage you to do is to call or set up a consultation. And as Dr. Danilyants mentioned in earlier today, we do have someone who's dedicated to kind of helping you understand whether or not your insurance is going to be able to cover the procedure that you need. So I'm going to highly encourage you to give us a call or schedule an appointment. We do take several insurances, so. You're very welcome. I will just stay for another minute or so. So you have access to the link, the evaluation link. I would also share it in the follow-up. So if you don't get to do it now, you will have it in the follow-up email. Thank you. Oh, yes, we have, if you're trying to access the archive of all of our Ask the Experts, you can just go to our YouTube channel. If you can give me a moment, I actually would share it with you. We have a list of all of our Ask the Experts is just archived. So I'll go ahead and share it in the chat box so that you have access to it. I'll also share it in my, I'll include it in the follow-up email also. Right, so this is it, and I will. And if you missed this link, I will include it in the follow-up. Thank you all so much, and I hope you enjoy the rest of your day. I'm gonna go ahead and end the webinar now. Have a good one.